The outline will be an introduction, the components, the functional and biological aspects, preoperative assessment, the surgical technique, and the complications. Now, an implant, it depends on a coordinated approach. It depends on multidisciplinary team. We need a good preoperative assessment for the implant site. We need good preoperative assessment to the surrounding teeth. We need very good prosthodontist. We need very good dental technician and a surgeon or a periodontist or prosthodontist sometimes can place implants. It's different in some countries. Some countries, the general practitioner can place an implant. Now, we will talk about the implant components. The implant, the part that we place inside of the bone, it's called the implant fixture or the root form. This is the one that looks like the root. Then we have the cover screw, which is this one, and the healing abutment. Now the cover screw, we place it on the implant at the time of insertion. If we're doing a two-stage approach, we will place the gingival former after 2 to 3 months of the implant placement. The healing abutment or the gingival former, this to form the gingiva to be pinkish and healthy around an implant. We place it usually for 2 to 3 weeks to make sure that the surrounding tissues is healthy. And the last part is the abutment, which looks like the prepared tooth to receive the crown. Now, the implant kit has many components. It has many components. First, we have the tissue punch, which is usually used for flapless surgery if we're not going to do a flap. We have the guide drill or the pilot drill. This would give us the initial path. We have depends on different systems, for example. We have some systems can have the 2 or um, the 2.0 drill as a start. Some have 2.8 as a start. It's different between different systems, but mainly they follow the same principle. Pilot, first drill, second drill, third drill, depends on the implant that we're going to place. Then we have the ratchet, the fixture adapter, the one that we place the implant with, and the ratchet usually for manual insertion of the implant. Now, what's the difference between an implant and a natural tooth? The implant is osseointegrated. It's a direct structural and functional connection, meaning the bone and the implant, they are attached to each other without any soft tissue, without any fibrous tissue, without anything, just the implant and the bone is surrounding the implant all over. Now, to reach osseointegration, that means we have successful implants. We have osseointegration, this means the implant is successful. Now, we need to have osseointegration, we need to have a biocompatible material, which is the implant. Atraumatic surgery, we need to be careful not to overheat the bone. That's why we have irrigation system, normal saline, to keep the bony temperature less than 47 Celsius. We place the implant in a position where we have bone all around and the implant to be immobile. Now, if we have these 4 principles, then our implant is supposed to be successful. But that's not the only factor. We have a patient factor as well that will help or affect the success and the failure of any implant we place. Now we have 4 types of bone. Type 1, which is mainly compact bone and slight cancellous bone. This is present in the lower anterior mandible. Type 2, it's usually present type 1 in the anterior mandible. It's very hard, very dense, and usually we can have very good osseointegration in these surfaces because we have mainly compact bone. Type 2, in the posterior mandible, we have a slight more amount of the cancellous bone. In type 3, we have more cancellous and a slight trim of the compact bone. This is present in the posterior maxilla. And type 4, which is mainly cancellous bone, this is present in the anterior maxilla, and this is considered the worst type of bone to place an implant in because it's very sorry for the mistake. Type 3 is present in the anterior maxilla and type 4 is in the posterior maxilla. Now, that's why type 4 is considered the worst type of bone to place an implant in. Now, the difference between an implant and a tooth is that in the tooth we have periodontal ligaments that attach the tooth or the root of the tooth to the surrounding bone. In the implant, we have bone. No periodontal ligaments in place, no periodontal ligaments around, nothing at all. Now, when we have a preoperative assessment for the implant, we need to be able to know the medical history of the patient, the dental history, any infection present, any type of prosthesis that was present before, and so on. Then we need to be careful to look at the surrounding structure. Now, if we have, let's say, for example, a lower 6 missing and we want to place an implant with, and we find the 5 and the 7 angulated to compensate for the space and the upper 6 is over erupted. We can't place an implant. We can't predict that we can put a good implant with a good restoration over it to allow function. So we need to look at the surrounding structures as well to be able to say this implant is going to be successful or is going to be failure, or we're just going to put an implant for nothing in this patient. Always, whenever we want to do an implant, always order a CBCT. We want to see the 3D quality of the bone. Now, a lot of times we will find, if we depend only on the panoramic X-ray, which is 2D, we will find that you open your flap and you find out that you don't have a lot of bone. You close again. That's why always order a CBCT to prevent any embarrassment between you and the patient and to prepare and to plan for your case. Let's say on the CBCT you found no bone or short vertical width. We can do bone expansion, we can do bone graft, we can do a lot of procedures that can be helpful. I can see the sinus presence. Is it close to the site of the implant or it's far? Do I need to do sinus lifting or not? So I would prepare for sinus lift procedure. And I would tell the patient about it beforehand so he will not be surprised and say, no, you didn't tell me about it. Now, the measurements that we need always to be adapting to and following them. 1 millimeter buccally and lingually. At least 1 millimeter buccally or lingually. 1 millimeter inferior to the floor of the maxillary or the nasal sinuses. The size of canal should be avoided. 2 millimeters superior to the ID canal and 5 millimeters anterior to the mental foramen. Because we have what we call the anterior loop of the mental foramen. We'll talk about it in a minute. 3 millimeters from adjacent implants and 1.5 millimeters from the roots. Now, this is the ID canal. This is forming the and the mental foramen, and this is what we call the anterior loop. Now, we need to place an implant at least 5 millimeter away from the anterior loop of the mental foramen to prevent any injury. Because if we keep it 2 millimeters away, we can have an injury to the mental foramen or the anterior loop easily and we will not be able to see it. That's why also planning is very important here. The implant was placed very lingually, but we have a lot of good surface for the bone. We have very good amount of bone to place an implant in. That's poor planning. We need to plan for our case very good to prevent these mistakes from happening, and this can injure the lingual artery. This can cause hematoma, sublingual hematoma. This patient might go into ICU because of this problem. That's why we need to be very careful. Now, as we said, the maxilla has poorer quality of bone, and we have the sinus. If the sinus is like in this case, we will need to do a sinus lifting. Now, if we have 4 millimeters of bone available, we can do indirect sinus lifting, in which we do the drilling and the implant will raise the sinus. Or the instruments, the osteotome, small osteotome would raise the sinus. But if we don't have, like in this case, we will need to do an indirect sinus lift or lateral window. We will raise it, put bone graft, and then place the implants. So the maxilla has two specific concerns: the quality of the bone and the maxillary sinus. So here's a case in which I want to plan for an implant. So here I measure from the buccolingual width, the buccolingual plates. To know the implant, I need to have 1 millimeter anterior and 1 millimeter posterior. And then I need to look at the length, 2 millimeter from the ID canal. So I should be in good control of the implant. So here are the surgical instruments that we need: local anesthesia, periosteal elevators, Selden retractors, curettes, scissors and needle holders, surgical suction, and so on. So preferably we should give the patient 2 grams of penicillin V 1 hour preoperatively, or IV dose of penicillin G. Alternative medications could be 600 milligrams clindamycin orally or intravenously, and no need for postoperative antibiotic administration. Now, to expose the site, we have flapless surgery, sulcular incision, mid-crystal incision, vertical releasing incision, and so on. Now, flapless surgery or punch incision when we have good amount of keratinized tissue. In the experienced hand, that's good. In the inexperienced hands, it's preferably not to be done, because you need to see the surface of the bone. You need to see where you're placing the implant. Here you're placing your implant blindly. So always, as a start, even in experienced hands, we prefer to go for the flap. So we can see the bone, we can see if the bone penetrated the buccal or the lingual plates, which is very common to happen due to poor positioning, poor angulation. So it's preferable to open a flap. Now the flap should be opened more towards the palatal. So the recession will happen more at the palatal site, and the buccally or aesthetically it will remain normal. We can do a releasing incision, sulcular flap with releasing, triangular flaps, rectangular flaps. We can do whatever incision we prefer. We can also use a surgical guide, in which this will be the position for the implant will be already planned. We place the implants in the position with the perfect angulation. The speed is 1000 to 1500 RPMs. We irrigate very good. All the drilling should be 1 to 2 millimeters short of the depth of intended implant. So if I'm placing a 10 millimeter implant, I will put an 8 millimeter drill. Then once I want to place the implant, I change it to 30 Newton centimeter for the insertion of the implant. And always we drill smaller length and a smaller width. Meaning, if I want to place an implant that's 3.75 in diameter, I'll drill for the 3.5 or the 3.25 and let the implant go into the bone and do the osseointegration itself to take the surface of the bone and allow the bone particles to attach to the implant to ease the process of osseointegration. Now, the complications, the normal ones: pain, bleeding, swelling, or infections. Invasion of the canal may result in paresthesia. Now, if that's why we always, the anesthesia that we give is infiltration. Because if we invade the canal, the patient will feel an electric shock. We change the position or raise the implant. Now, if it's after a while, like let's say we placed the implant and everything was fine, then the patient went home after a week, he said the paresthesia is still present. Sometimes we need to remove the implant or do lateralization of the nerve to facilitate the process. Now, if it invades the sinus, it can result in infection. It's usually removed. But if it's good position, we can leave it. It's the complications because of the positioning or the angulation. The prosthetic restoration is unrealistic. It's not going to be, the patient will not be happy. Mechanical complications such as fracture because of excessive torque. That's why we leave it at 30 to 40 maximum. So here, some people use a round burr to initiate the first implant placement. Then we use the pilot drill to go all the way. Now we usually use the pilot drill 2 millimeter below the intended length of the implant. Then we keep drilling with the normal drills that we have. This is the depth to see if we can place an implant as the position we want or not. Then we can place the implant at a small torque, at a low torque. And then we suture it. Usually the preferred suture in such cases, figure of 8 or horizontal matrix sutures, not simple interrupted, to make sure that we cover all parts of the gingiva around the implant. And here's a case where the flap has been opened. Then we start with the pilot drill. As we can see, the irrigation coming through. Here the sequence of drilling, wider drill every time. And we can see the osteotomy of the implant. And here the placement of the implant. As you can see, the torque is low. I want to see, and here the placement of the cover, the ratchet and manual insertion of the implant. Now here is the second implant. As you can see how it's going down. Here I only need to raise the torque or do manual insertion. So here's a case. As you can see, we have a remaining lateral incisor root. We have good amount of bone palatally and apically. So we did extraction for this case and immediate implants. As you can see, this is the bone graft that we place. When the immediate implants, we place it more palatal because a very common problem is that we will find the buccal plate resorption. So that's why we put it more palatal, and in the gap between the implant and the bone, we place the bone graft. And this is 1 week post-op, and we're waiting until we can find good osseointegration of the implants. Here we can see 2 implants. This picture is for the case that the video had. Good. Now, one mistake is that this is supracrystal. I should have placed it more apically a bit, but it shouldn't be a problem in some cases. We shall wait and see. And hopefully this cleared some of the features of implants, helped guide you in some way, and hopefully you enjoyed it. And if you have any questions, I'm always available. Thank you.